On again, and so let's say somebody's had gone down the orthobiologics route, and they've now started to get maybe it's a few years down the line, and it's a little bit worse than things were, and they've mitigated, they've strung things out a little bit. They're looking to maybe have to look into something different, or let's say their injury itself is more severe, and it's maybe not like what we might call a grade 1 or 2 or even 3 cartilage lesion, but it's like a grade 4, meaning, so for those that don't understand, meaning that it's now down to the raw bone. So if it was a crater, you've gone through the complete cartilage layer, you're now down to bone exposure. Can you give us a quick overview on options for those sorts of individuals?
Well, something I've been really interested in the grade 4, as you say, where the articular cartilage is almost non-existent. When you assess the patient, we're looking at the knee. The alignment of the knee is going to be important, whether there's increased load on one aspect of the knee. You can still consider non-operative measures, which include bracing, looking at their shoe wear, supportive shoes to take the load off the knee. And the age is going to be very important too, because what we want to try and do is delay as long as we can while maintaining their function. Admittedly, I have had patients in their 50s have had to replace their knees because we've exhausted all the other methods of treatment. One of the things that I find really interesting, particularly the individuals who have normal alignment, is a subchondroplasty, which I think we talked briefly about. And the idea about it is, again, the mantra I have is cartilage is avascular, aneural, alymphatic. So the question people will ask, where's the pain coming from? And in some instances, when the patients present and are assessed, the x-rays show degenerative change, but they have pain that just seems to be out of proportion to what you would see on the x-ray. And the next course of planning would be an MRI scan. An MRI scan may show bone marrow edema, which is an area where increased stresses to this, what we call the trabecular bone, which is, forgive me if I appear to be simplifying it a lot, but the trabecular bone is under stress. And when it's under stress, you have edema, and the edema increases the pressure in the bone and causes pain. So subchondroplasty I've been doing for the last 3 years now, and I must admit I have been amazed. I can give examples of a 65-year-old who I would have sworn he needed a knee replacement, but he was fearful of losing his job. And the recovery time before return to work would be 2 to 3 months. And I explained other options and went down the route of a subchondroplasty. He had me do a joint degeneration. And touch wood, it's probably 6 to 9 months now, and he wants the other side to undergo a subchondroplasty. He's so pleased with his left knee.
The other side of his knee, or the other joint?
Oh, the other joint. He wants his right knee treated by subchondroplasty. So that's been favourable, and so far, I haven't had anyone complain about pain, which is just tremendous news. Admittedly, it's a small number, but it's something I offer patients.
And sorry, go on, Harold. Yeah.
The ones that look at evidence, because subchondroplasty is probably about 9 to 10 years old.
Yeah.
Some will want a quick fix, and the options available are either an osteotomy to realign the joint, a partial knee replacement, or a total knee replacement. And the results for patients who are in their 60s are very, very good for total knee replacements. And off-the-shelf total knee replacements have a lifespan for between 15 and 20 years, depending on the age of the individual. The younger they are, of course, and more active they are, the shorter the lifespan. Up to 10 years for someone who's 50 and very active.
Okay.